So I would say that the short answer is that if the patients are decompensated with complex lesions and we are going to anticipate a lot of ischemic time, then it is worth it. Otherwise, I rarely use it. I'll review some data and show you some cases. So the most important thing, if you look at United States in 2020, this is the nationwide registry from NCDR. It's very clear that the people are using more and more Impella compared to balloon pumps. So if you look at it in the Impella era, it is almost 30% Impella compared to balloon pump. And if you look at the different hospitals, they are 5 times more likely to use Impella than the balloon pump than in the past. So this is something very a trend. And unfortunately, despite using Impella, the death rate, bleeding rate, AKI, stroke, nothing is decreasing. They remain the same. Now, obviously, there is an issue that people who are sicker, they are using Impella. So this is one of the considerations that maybe this is not fully adjusted or cannot be fully adjusted. But irrespective, it's not changing. If you look at the different markets, very similar data now from 2022. If you look at it, the MCS, meaning either Impella or balloon pump, both together, the rate is increasing. And as you can see, the total number of procedures, 15,000, so large number of patients. However, if you look at the adjusted mortality, in 30-day adjusted mortality, risk adjusted, no different in the people that are used with MCS. And the cost is going up so much. So it's from $32,000 to $40,000 per procedure. And it is very interesting that most of these patients who are having the second bullet point there, the patients with acute MI, cardiogenic shock, who are not being treated with Impella. It is more of stable patients. So it is kind of strange to understand. So I thought, let me just show you some cases. So this is the first case that I'm going to show, is a case that I didn't do. One of my colleagues did it. So 70-year-old gentleman, normal LV function, CHF, he has 70% distal left main, circ and ostial lesion. There is a 70% proximal RCA lesion. And the question, this is the typical distal bifurcating left main disease, and it's a diffuse disease. So the question was raised that what should we do? So what he decided, so this is a good format that I typically like to say, that what is the cardiac reserve? So the cardiac reserve in this patient is normal EF, normal LVDP. Lesion complexity, intermediate, it's not super tight, it is easy to wire, and so it's probably intermediate distal left main. And RCA is diseased, but is not occluded. And the MCS risk, the groin access is good, so the MCS risk is low. So what they decided to do was to put an Impella, and they did the DK crush, that what Ramesh was pointing out to you. And the DK crush, good result, patient did well. My perspective, that it is a reasonable thing to use, but this is not an uncommon practice in the United States. I would not have used it. That's what I said, because I think the argument was that when they did this procedure, the pulsatility was lost, and what the patient would have been unstable when they did this procedure. I'm not so sure, maybe slightly hypotensive, but it won't matter. So now I'm going to show you some more cases. So this is a 70-year-old again patient. Now these are all going to be TAVR-related left mains, because I just picked up from last 1 month that I did. So here, this is a TAVR, and the left main stent was done at another institution. Patient came with a severe shortness of breath, got intubated in Cleveland, and then had a CKMB of 1,000 and 100. Left bundle branch block on the EKG, we couldn't tell. Patient was extubated, still short of breath. And the cath, I'll show you, but 70% left main. LVEDP was 30. And I was planning to just, and I'll show you. So this is what we found. So this is, as you see, there is a TAVR valve. There is an ostial circumflex lesion. There's a distal left main lesion. And the LV and diastolic pressure is 28-30. So, the guy, definitely decompensated. LV function is normal. He's a friend of mine, interventional cardiologist himself, the patient. So I would say that this is a cardiac reserve is relatively low. The lesion complexity is intermediate. I thought it was not so bad, but I'm going to show you what happened. And then the RCA status was okay, RCA is fine. And MCS risk, I call it intermediate because there is a prosthetic valve. I said, I'm not going to use it. I'm just doing radially. So here I wire the left main, but unfortunately the left main stent is sticking out. So left main stent is coming out of the left main, and as you can see, I IVIS it, and the left main is on the other side, the catheter is on the other side. So normally in this situation, I like to put a 035 wire. So I put a woolly wire and put a glide catheter and then wired in the lumen. Not easy to do, especially with the TAVR valve, but we did it. And then very simple after that, just put a stent in the circumflex, part it, and then do a kissing thing. Patient did well, and the results were outstanding. So again, no need for MCS in this kind of a situation. Another case, now 60-year-old patient with a porcelain aorta, had a TAVR. I had put a TAVR valve 5 years ago, and now the patient has a totally occluded right coronary artery. I had stented it, but it's closed now. Patient is short of breath, I'll show you, and severe MS with a mean gradient of 10. So here you can see the right is totally occluded, stented, left main is super tight, LAD is super tight, TAVR valve is there. But LVDP is not high, LVDP is low, 8, mitral gradient is there, 10, and the aortic valve is functioning well. So hemodynamic assessment is super important. So I call it the cardiac reserve is intermediate. Lesion complexity is complex because the right is totally occluded, left main is messed up, RCS CTO, and intermediate because we are, again, groin access is so-so, and we have to go through the valve. So my plan was to fix the CTO of the RCA, and if everything goes well, then I'll rotablate stent the left main and perk MVR later. Of course, whenever you are doing a CTO, it takes a little time. You see the porcelain aorta, and as you can see, the wire is going in wrong places. Finally, I could wire it. Very diffusely diseased RCA, as you can see there. So finally, I put a long stent in the RCA, and the RCA was revascularized. And at this point, we could rotablate, as you can see the rotablator. I like to rotablate with a small burr, 1 to 5 burr, and then stent the LAD and the left main. Patient did very well. Actually, I discharged the patient next day. Last patient, 91-year-old patient, came with a chest pain, shortness of breath, non-STEMI. CAT shows 90% left main, 90% LAD, circ is 60-70. His guy is 90, so I have a simple rule. Just treat the lesions that are more than your age. So I said, we are going to treat 90% lesions, otherwise not. And he has severe AS, 2 plus AR, mean gradient is 50. LV function is normal. So this is how his left main looks. This is how the aortic valve looks. LAD, of course, everything else is diseased. The guy is 90-year-old. And the right coronary artery, amazingly good. And the LV and diastolic pressure is low. Gradient is high, as I said. So what would we do? The idea would be to say that we can put an MCS and then treat the left main, or do a balloon valvuloplasty and then do the left main. These days, TAVR is so simple. So I would say instead of putting an impeller, I would rather put a valve. So I put a valve in him. So I would say that cardiac reserve is low, lesion is simple, RCA is okay, and the risk is intermediate. Here, after pacing, I put a TAVR valve. Just after the second beat, the blood pressure is fine. So no real problem after that. So, and then we rotablated and stented. I couldn't put that particular picture, I tried. So the idea was that in my mind, the impeller and all this MCS is infrequently needed. It is overused. I tell all our cardiologists that be very cautious because it causes complications and it's not worth it. If you can simplify the left main intervention, that's crucial. You don't want to be stressed, you don't want people to be stressed, and you don't want to keep doing things that are not absolutely necessary. So this is important, that keep it simple. And don't spend so much money. There is no clear advantage in the literature. So again, try to have a simple procedure is better. Thank you for your attention.